Shabu for his kind invitation, and also Diabetes India for hosting us and having us here. It is wonderful. We're having an awesome time. I also wanted to remind you that you haven't been reminded that we've got the Western Pacific IDF meeting in Melbourne, the 18th to the 21st of August. Professor Jonathan Shaw is the convener. Professor Alicia Jenkins, as the Western Pacific IDF president, is overall responsible for the success of this, and we are hoping that everybody can come. Now, in Australia, I'm going to take a much bigger view of the world that we live in Australia, and talk about some of the stuff that's happening at our national level. In Australia, we have this scheme called the National Diabetes Services Scheme. It is a government-funded scheme that provides services and support to people living with diabetes. If you're living with diabetes, you can get stuff through access points, usually community pharmacies, and through the NDSS agents, the state agents. And so what do you get? You can get stuff like urine test strips, you can get your insulin syringes and your pens, you can get your insulin pump consumables, not the pump, but the consumables, and you can get CGM for people with type 1 diabetes. These are all subsidised by the government. Because of the NDSS, and because you have to be registered with the National Diabetes Services Scheme in Australia to get access to these services, we have data like this. And this is the number of people who have diabetes in Australia that are registered with the National Diabetes Services Scheme. Probably not 100% complete, but gives us a reasonable indication. So in Australia, as of December the 31st of 2025, there's 1.25 million people with diabetes. If we take it that the population of Australia is 28 million, that's about 5.6% of the total population. Mostly, as you can imagine, it's type 2 diabetes, 1.32 million. There's 145,000 people with type 1, and there's about 40,000 people with gestational diabetes. Now, this is how it compares to India, and you know this data quite well. There's about 108, 110 million people with diabetes in India, or 11% of the population. Now, because we have this data over 40 years, we can have these trends of registered people on the NDSS. And for type 2 diabetes, over the last 10 or 12 years, there's about a 40% increase in the number of people registered with the scheme. There's also about a 30% increase in the number of younger adults getting diabetes, type 2 diabetes, and we know that that's, the environment, the obesogenic environment is actually bringing out the disease, is shifting the curve to the left, and more registrants are on the NDSS, 21 to 39-year-olds. Now, of interest to us is that people treated with insulin over the last 10 or 12 years has increased by 50%. Is that a good thing? Is that a bad thing? Are we doing well and we're treating people with insulin, or are people not doing well and we're using more insulin to try and manage their glucose? In Australia, and I sort of want to talk a little bit about the healthcare workforce, diabetes, type 2 diabetes, is mainly managed in the primary care setting. There's 35,000 GPs in Australia. There's 1,100 or thereabouts of endocrinologists, and there's about 1,600 CDEs. So you can see that the burden of disease is really managed in primary care. I say that sort of with some caution. The healthcare system here, it shows that the majority is primary care driven and hospital driven, and that's largely supported by government, both the state and the federal government. And that's all I wanted to talk about in this context. So we have a large number of people with type 2 diabetes, and we have a health care force that's attempting to manage that increased burden. Now, the other thing that we have in Australia is the Australian Diabetes Clinical Quality Registry, which the ADS is responsible for. It's a registry that has both primary and tertiary care hospitals contributing data to it. And it's about improving clinical care, it's about benchmarking, and it's about adhering to national standards. Because of this registry, we have data like this. And this data shows that over the last 12, 13 years, since 2012, that I've put this data together, the mean HbA1c for people with type 2 diabetes in this registry has not changed. This is despite better care, newer drugs, more effective drugs, perhaps more insulin use, better treatment algorithms, better awareness. HbA1c hasn't changed. Again, is this a good thing or is this not a good thing? Is the fact that it hasn't increased over the last 10 years a good thing and it's sort of stayed quite stable? Because, you know, we're not going up, but we're not meeting target of 7 or less. Now, it's important to note that although tertiary and primary care centres are contributing data to this, the majority, 2/3, comes from hospitals. And you can imagine that hospitals would be seeing the more severely affected people with type 2 diabetes. We also know that from this registry, only 30% of people with type 2 diabetes are meeting the target of 7 or less HbA1c. And I've just highlighted at the bottom there that in terms of BMI, 25 or less, only 15% are meeting that target in this cohort of people. What about medications? Well, here it is. This is what people are being treated with. About 76% are on metformin, 50% are on SGLT2. 1 in 2 people in Australia with type 2 diabetes seem to be on an SGLT2. 35% on a GLP-1 receptor agonist. There's a significant proportion, about 25% on a DPP-4 inhibitor, and about 1 in 5, 20% are on a sulfonylurea. And if you look at the trends over the years, since 2015, so 10-year data, there's been an increase in the number of people treated with metformin. SGLT2 inhibitors have gone up to 50% from about 4.5% in 2015. Significant increase in GLP-1 use, a steady use of DPP-4s over the last few years, and sulfonylureas. And you can see at the bottom there, I have highlighted insulin. And about 50%, 56% of people in this cohort are on insulin, and that seems to be steadying. Now you could ask, well, you've got data from both primary and tertiary level centres, how they're faring in terms of medication use, and I'm surprised at this, that there's very little difference in the medication use between primary and tertiary care centres. I would have thought that there'd be more medication use in tertiary level centres, but there isn't. And then it's not surprising that the HbA1c, this is for the total cohort, including type 1 diabetes, is not different between primary and tertiary level centres. Very interesting indeed, given that you would think that the more severely affected people would be referred to a tertiary level centre. Now, this is interesting data that an eminent endocrinologist in Australia called Shane Hamblin has done over the last few years, and has tracked the prescriptions for non-insulin glucose-lowering drugs for type 2 diabetes. In the red is what you would predict for the prevalence of diabetes. In the black is the actual number of prescriptions over the last 10 years, 2013 to 2023. And you can see a significant discrepancy with a much higher number of the observed prescriptions compared to prevalence. So we are prescribing more. Are we over-prescribing? Are we not prescribing it appropriately? It's not surprising that the most prescribed drug, as I showed before, is metformin in the green, and then you can see in the black is the sulfonylurea and the quite steep increase in sulfonylureas. The red line is DPP-4 inhibitor prescriptions, and in the blue line a little bit further down is the GLP-1s, and that is rising. And again, I guess not surprising that the most costly drug apart from insulin in Australia is the GLP-1 receptor agonist, and then followed closely by the other newer kids on the block, SGLT2 inhibitors in the black, and the DPP-4 inhibitors in the red. Now, we're using a lot more drugs. Are we using them well? Is our treatment algorithm appropriate? This is the type 2 diabetes treatment algorithm in Australia. This is what we are responsible as an organisation, the ADS. I want to point out that this is a glycemic management-based algorithm with risk management sort of intertwined. And we do talk about lifestyle straight up and talk about diet and exercise, and that continues throughout the treatment algorithm. And we do have an obesity management algorithm that is linked to this document. And then, of course, we've got our first-line therapy, which is metformin. The blue boxes are what are subsidized for use in type 2 diabetes, and the ones that are commonly used in type 2 diabetes in the dark blue, although insulin is also subsidized for monotherapy use in type 2 diabetes, metformin, and then either an SGLT2 or GLP-1, depending on tolerance and contraindication. And the green dots mean that there's a recommendation that these should be used as second-line therapy because of the cardiorenal protection. And we've got a table of evidence on the back of that for more information. We've also got a living evidence guideline in Australia that talks to the use of pharmacotherapy in type 2 diabetes, again recommending for the use of SGLT2 and GLP-1 because of the cardiorenal protection in people with type 2 diabetes, and recommending against the sulfonylurea predominantly because of its hypoglycemic effect. We've also got the obesity management algorithm, as I discussed before, and then that talks about the classification of obesity, the baseline complications, obesity targets for weight loss, the health services that should be responsible, and so on. And this is the treatment for obesity in Australia. We've got a number of drugs that are approved but not subsidized for use in obesity. We've also got standards. So we've got the National Association of Diabetes Centres. The NADC is a division of the Australian Diabetes Society, and that sets standards and an accreditation process. And many services are accredited through the NADC because they perform at a very high level. If anybody's interested, these are the standards here. So we've got increasing medications, we've got treatment algorithms, we've got standards, and we've got models of care. And I'll take you through a couple of models of care. This is the Diabetes Australia program that's run through the New England Hunter region, with Shamacharya being the leader of this, and it's about upskilling GPs and providing support to GPs from the tertiary hospital centre that is in that area. Is it effective? Not quite sure. This is another model of care that Tony Russell has run in Queensland and is trying to reproduced in Australia. It's called the GPs with Special Interests. The GIPSY program or the Beacon program, where you're taking GPs who want to learn about diabetes management and upskilling them over a 12-month period, and then you are creating these Beacon clinics where that upskilled general practitioner, together with an endocrinologist and or a CDE, will have referrals from the surrounding GP clinics of complex cases that can provide a little bit more support. Is there evidence for this? Well, I would not want to take you through all of this. Suffice to say that there is a small reduction in HbA1c, which is less so at 12 months, and there is a sustained reduction in systolic and diastolic pressure. Diastolic pressure. And again, this is the Western Sydney Diabetes model of care with Glenn Mabley at the helm, complex model of utilising primary health networks, utilising general practice and upskilling general practice, as well as community centres and the hospital. We've got a models of care toolkit that you can access if you want more information. So, models of care, algorithms, and drugs. We also in Australia have a national diabetes strategy that is government-owned and government-driven. And it's got 7 goals, as you can see up there, and it spans the whole gamut of diabetes and its management, prevention, screening, reducing complications, impact of GDM, the impact of diabetes on our First Nations, Aboriginal people, and so on. What has happened? Not very much. We also recently had an inquiry into diabetes that, again, the government initiated, and that listed 23 recommendations, which I don't want you to read here, but there is all of this stuff. And yet, HbA1c is stubbornly not moving, despite the increase in medication use, treatment algorithms, models of care, and all of this strategy and policy from the government. What's the missing link? Is there a missing link? And if people are old enough like me, they would remember the missing link, who was a wrestler in the WWE. And I've put here a number of thoughts, and it could be models of care. We don't have the right models of care. It could be funding of hospital services, and we need more of that. It could be empowering and educating GPs. It could be equitable and affordable access to technologies, referral pathways to CDEs, and other stuff. And I would like your thoughts on this. Now, suffice to say, this is data from the Baker Institute in Melbourne, where because of the lockdown, the COVID lockdown, and the difficulty in getting medications, we can see in the top panel that the shortage of GLP-1s during that period, that 2021 to 2023 period, that had an effect on HbA1c. Not on weight on the lower panel, but on HbA1c. So clearly access to medications is important. This is true for Aboriginal or remote communities in Australia. On the left is a community that did not have access to once weekly exenatide, Bajurian. On the right is a similar community that did, and you can see that there is a significant reduction in HbA1c in the community that had access to liraglutide, to exenatide. What about CGM? This is a study where they gave CGM to people with type 2 diabetes on insulin, and you can see that in the black bars that HbA1c was reduced by about 0.32% in the people that use CGM, the people with type 2 diabetes on insulin that use CGM, and that was sustained for the period of the study. And if the starting HbA1c was 7 and above, that reduction was greater. So, the last 35 seconds, final thoughts. The number of people with diabetes in Australia is increasing. The number of the pharmacotherapy use for type 2 diabetes in Australia is also increasing. But glycemia remains stubbornly higher than maybe what we would want. So a multidisciplinary, holistic approach may be required to provide better care to the person living with type 2 diabetes. I would like to finish in the last 5 seconds with this. This is the great battle between Alexander the Great and Darius III, the Persian king of kings, Darius III, the Battle of Issus, in which Alexander defeated for the second time the king of kings, Darius III. Focus, strategy, determination is probably what we need. Thank you very much.